Benign, definitely. It looks like a pearl. It's a keratin pearl arising from the caruncle. Okay. So now today I'm gonna deal with malignant conjunctival tumors, and the objective of my presentation today is to clinically being able to differentiate between a benign lesion and a malignant lesion, because the management, the recurrence, and the mortality and the outcome of the patient basically depends upon how you diagnose initially when the patient comes to you in the clinic. Differentiating features, diagnostic aids, and other miscellaneous tumors. So when we talk about conjunctival tumors, we always divide it into non-melanocytic and melanocytic. So is this benign or malignant? Since you already heard the benign conjunctival tumor, it's going to be quick and easy. Malignant? Well, melanocytic. Malignant. So there are definitely certain features which made you think that it is malignant. Mostly it is the elevated lesion. It will be more dense, right? And especially, be it a non-melanocytic lesion or a melanocytic lesion, certain things that we always look for to differentiate between a benign and a malignant lesion is mainly this feeding tumor vessel, right? The intrinsic vascularity. And in melanocytic lesions, there will be differential pigmentation of the lesion, and it looks fleshy over here. Now, this is an Asian male who presented with a white lesion in the caruncle over here. To take a closer look, lot of keratin deposition. As you can see in the adjacent area, there is thickening of the conjunctiva over here, like nodular thickening. What are the differential diagnoses that you would think of? Yes? Caruncle, you can have any tumors in the caruncle, right? Because you have hairs, you have sebaceous glands, anything. Papilloma? OSSN? All right, yeah. So history is very, very important. So this patient came into the clinic. He never gave us the history, but he had a long-term history which was taken later, that he had undergone lacrimal intubation, like 25 years back. So there was actually a tube which was sitting in there. A tube that was sitting in there which caused this granuloma. So it's very important, differentiating these inflammatory condition also, which can actually simulate a malignant lesion. This is unilateral blepharoconjunctivitis. Anyone would think with a history where the patient says that repeated redness, the redness which is not going away with treatment. But as you can see here, there are specks of keratin over the surface, and this is the clue of a bad lesion. So a diffuse conjunctival squamous cell carcinoma can present with a unilateral blepharoconjunctivitis, but what you have to look for in this particular cases is the presence of keratin, and that is a giveaway. Now, they can also present with, this is actually, who presented as a corneal scar and underwent PTK. But again, you can see these traces of keratin over the corneal surface. Similarly, this was diagnosed as necrotizing scleritis, but there is chunk of keratin sitting over the lesion. So there are certain features which I will come into, which helps you to differentiate between a malignant and a benign lesion. Now, here you have an elevated pigmented lesion with another melanotic component of the same lesion over here. Diagnosis? Straightforward, right? Conjunctival melanoma. Well, this was a melanoma which was arising from the nevus, which is adjacent to that. So first we'll go on to the most common conjunctival malignancy, the ocular surface squamous neoplasia. It is in fact a spectrum from dysplasia to carcinoma in situ to squamous cell carcinoma. And it's a blanket term which is used as OSSN. Now, conjunctival SCC, it's the most common, as I told you. It is in fact a low-grade malignancy, but it can be aggressive in those patients with immunosuppression, like HIV, renal transplant, who's on long-term immunosuppressive medications, and even in those patients with xeroderma pigmentosum, they can have aggressive bilateral and recurrent tumors. So these are the certain other systemic association. Apart from that, plantar keratoderma, which is very rare. I'm not going to speak on that. So this is how, the relentless the tumor can look like in an HIV patient, where they can have like real bad lesions coming up in a very young patient. Any patient coming into your clinic whom you're suspecting ocular surface squamous neoplasia in a young patient, always advise serology. HIV, please rule out HIV. So this is another case of renal transplant patient where the patient had a squamous papilloma in one eye, which was, with a squamous cell carcinoma in the other eye. So usually it has a perilimbal location, interpalpebral, and it can also extend into the cornea. So these are the different morphological types. It can be nodular, it can be gelatinous, it can be papilliform, and in our population, especially the pigmented population, they can present as pigmented lesion. Now, these are the characteristic clinical features which helps you to differentiate SCC, the squamous cell carcinoma, from other benign lesion. Presence of keratin, rose Bengal staining, feeder vessels, intrinsic vascularity, corneal encroachment, and scleral fixity has to be looked into. And if you're suspecting squamous cell carcinoma, always look for regional lymph nodes, the preauricular and the submandibular lymph nodes. Well, so we did analyze a series of cases with Dr. Hunavar, and then we found that the presence of all these three features, keratin, the vascular pattern, and rose Bengal, there was 97% sensitivity and 98% specificity in differentiating these lesions from a benign lesion. So these are the characteristic features of OSSN. Well, it can involve the entire cornea also, and they can present sometimes with nodular lesion, not much of keratin. And these are the invasive kind of lesion. They're mucoepidermoid. It's filled with mucoid material inside the lesion. Other aggressive variants of squamous cell carcinoma are the spindle cell squamous cell carcinoma and the adenoid squamous carcinoma. Well, diagnostic modalities in these particular cases is very important because these are lesions with scleral fixity. You want to identify whether there is any intraocular invasion. So ultrasound biomicroscopy or anterior segment OCT would help you to know whether there is any intraocular extension to plan the management. Now, in fact, these patients, it's a clear-cut case where there is proptosis, history of ocular surface squamous neoplasia. So this is an orbital extension. So you want to actually image and also see with a CT scan what is the real extent, whether it's extending into the paranasal sinuses or even intracranial extension. Now, modalities of lesions. Like we do anterior segment OCT, most of the time clinically it gives away the diagnosis, but these are modalities where you can actually know the thickness, whether there is any corneal invasion or scleral invasion in these particular cases. Often it is useful in these lesions where the keratin is low, but as you can see here, in lesions presenting with lot of keratin, there is always a backscattering. It's very difficult to identify the posterior extent of these lesions in this particular situation. We also classify it under AJCC classification. I'm not going into the detail because we are short of time. So basically you classify into T1, T2 depending upon the diameter, T3 depending upon invasion of the adjacent structures, and further extension into the soft tissues and bone invasion, it's T4. I'm going to skip it. Management will be dealt with Dr. Hunavar, and we always follow a protocol-based management in order to reduce the recurrence and improve the survival. Now, what I want to stress here for clinical part is clinical documentation is very essential. So this is exactly how we take our images into the OR, in fact. So we draw it in the clinic and we actually hang it in the OR so that we exactly know the extent of the lesion, because for us, surgical management is clearance. We have to have 3 to 4 millimeter clearance of the lesion. So we actually draw it down and even find out how much. So this is like the keratin filled area, but they do have conjunctival thickening, so that is also included. You just cannot excise this area only with the keratin. You should identify in slit lamp biomicroscopy even the extent of conjunctival thickening in this particular situation. So clinical documentation is very important for a surgeon. Other lesion, conjunctival lymphoma, this is also actually a spectrum similar like OSSN. It is a spectrum of reactive lymphoid hyperplasia and atypical lymphoid hyperplasia and then conjunctival lymphoma. So usually it has the typical salmon colored appearance. Now the importance in conjunctival lymphoma is the systemic association. All right. So when do you want to actually investigate the patient? So as you can see here, this is from various literature that systemic association is 17% in cases of unilateral lymphoma and 47% if it is bilateral. So we would advise any patient who is histopathologically confirmed to have lymphoma of the conjunctiva, all of them undergo CT scan of the chest, CT scan of the abdomen, and we also do liver function tests to rule out systemic metastasis. Now, the prognostic factors of systemic metastasis, it's multifocal, bilateral, involving the fornix and the palpebral, and the most common is the malt lymphoma. Histopathologically, they can overlap many different types, and that is why immunohistochemistry plays a very crucial role, and Kaustav will be talking about that. There is also association of Helicobacter pylori infection with lymphoma. I'm not going into the details of the percentage. Now, management is again systemic workup, as I told you, and rest will be dealt by Dr. Hunava. Melanocytic, quickly going into it. Benign lesions has been covered by Dr. Menon, and conjunctival melanoma is the most important conjunctival pigmented malignant lesion, and it is a very lethal tumor because it has got a high mortality rate. So it is very essential to differentiate conjunctival melanoma from PAM, because again there can be a PAM which is turning into a melanoma. You should be able to identify it because 75% of the melanoma arises from a PAM, and so is from the nevus, 5%. So you should need to identify the features where you can differentiate between a nevus and a PAM, which Dr. Menon has already spoken about. I'm not going into it. Main thing is the presence of cysts, microcysts and macrocysts in the nevus, which help you to differentiate between a nevus and a melanoma. Primary acquired melanosis again. So what we have been taught by our mentors is, like, depending upon the clock hours, you can actually evaluate and assess whether this PAM can turn into malignancy. So the larger the clock hours, 12 clock hours, that means the relative risk is much, much higher than having 1 clock hour. So that's very essential. And also depending upon the location, palpebral conjunctiva, fornices, caruncle, etc. has a higher chance of turning into conjunctival melanoma. I'm not going into this because Dr. Menon covered it already. Systemic association, yes, and there are higher chance of them having conjunctival melanoma if at all they present with PAM and nevus. So usually it is elevated, nodular, very fleshy in appearance with prominent tortuous feeder vessels and intrinsic vascularity. They may not be always pigmented, especially in Caucasian races. They can be non-pigmented amelanotic conjunctival melanoma also. In the caruncle, it is very risky. So there is a high chance that this patient can have intraorbital extension. De novo, 20% of melanoma can arise, and from conjunctival nevus, 5%. So immunohistochemical studies also kind of help you if you're at a fix with a clinical diagnosis to differentiate between a nevus and the conjunctival melanoma. It's mainly HMB45 and K167. So this is why conjunctival melanoma is very, very important. It's more important than OSSN because the regional metastasis is as high as 40% and systemic metastasis is as high as 25% with conjunctival melanoma. You can never take a risk with conjunctival melanoma. So there are certain clinical features which helps you to know whether this patient has high risk for systemic metastasis: thickness of more than 2 millimeter, large basal diameter, nodularity, non-limbal in location, margin positivity if you have excised it, orbital extension, and de novo in origin. So mortality at 15 years is 32%, which has been reported by conjunctival melanoma. So I just want to sensitize you. If you find a fleshy lesion in the conjunctiva, the protocol-based management has to be followed because this patient can die after 5 or 10 years. All right, I'm not going into the AJCC classification, but we make sure in a clinic that all these patients are classified under AJCC. So yes, as I told you, so this patient underwent imaging and he has the anterior orbital extension. So any caruncular lesion, there may be high chance. Sentinel lymph node biopsy is something which has come up recently and there is a lot of controversy around it. So there are certain indications where you want to go ahead and do a sentinel lymph node biopsy. And this is a wonderful paper brought in by Dr. Kivala et al., where they saw that more than 2 millimeters thickness of conjunctival melanoma had a rate or cumulative incidence of 30% of systemic metastasis. So, well, most of the people, they do sentinel lymph node biopsy as a practice nowadays if the conjunctival melanoma is more than 2 millimeters. Now, in Caucasian population, again, you have to look for systemic evaluation, any pigmented lesion. It can be a skin melanoma, which is spreading into the conjunctiva. Diagnosis? A refresher one. Easy. Benign, malignant, subconjunctival hemorrhage. I'm done. This is my almost last slide. Yeah? Subconjunctival hemorrhage. Can you think of any hemorrhagic malignant lesion of the conjunctiva? Kaposi sarcoma, okay, immunocompromised patients. So it is also actually malignant. So HIV-associated Kaposi can be treated completely by heart therapy. Otherwise, it has to be taken care of as a malignant lesion of the conjunctiva. Last slide, but not the least. Diffuse congestion of the conjunctiva. Diffuse congestion of the conjunctiva. Lots of vascularity over here. Anything which is very catchy? Pagetoid sebaceous. Okay, so these can also present as a conjunctival tumor. But again, you have a very catchy point over here. Sebaceous gland carcinoma arises from the sebaceous glands of the tarsus, right? So you can see the most typical features are the loss of lashes, thickening of the eyelid, and rounding of the posterior edge of the lid margin. So this is a pagetoid spread, intraepithelial invasion of sebaceous gland carcinoma. So in fact, it has a very wide spectrum, both benign and malignant, but what is most important is an accurate clinical diagnosis, and so that you may go ahead with a protocol-based management and improve survival and reduce recurrence rate in these patients. Thank you so much. Thank you for your patient listening.